Good evening, students. In the previous six lectures, we have discussed about the basic concepts of the biopharmaceutics, what is the absorption mechanisms, and what are the factors affecting the drug absorption. Now we have shifted towards the next module, that is drug distribution. So, drug distribution is basically a part of ADME process, that is absorption, distribution, metabolism, and excretion. And this is the ADME process which is responsible for the drug action starting from this administration at a particular site to excretion. So drug distribution is basically when we talk about the drug entering into the bloodstream, the drug is subjected to a number of processes called as drug disposition process that tends to lower the plasma concentration. So distribution, it involves the reversible transfer of a drug between the peripheral and central compartment. So elimination, which involves the irreversible loss of the drug from the body, which comprises of biotransformation and the excretion. The definition is around that basically drug distribution is defined as the reversible transfer of the drug between the one compartment, that is basically central compartment, there is a larger compartment that is filled with blood, to another compartment that is called peripheral compartment, that is called extravascular tissues. So basically the distribution between these distribution of the drug between that two multiple compartment, it correspond to metabolism and the excretion in the particular urine. Significance. So pharmacological action of a drug, it depends upon its concentration at the site of action. So thus distribution plays an important role in the onset of action, intensity of action, and the duration of the action. Steps in the drug distribution. So basically the mechanism of the distribution, it involves the permeation of free drug, that is basically protein unbound drug, through capillary wall and it enter into the extracellular fluid. So when the drug it enter into the extracellular fluid, membrane permeability happens depending upon the what is the molecular size of the drug. For example, if the molecular size is around 50 daltons, so the blood is been traveling from the intracellular to in extracellular fluid through bulk flow mechanism. When we talk about the lipophilic drugs, so the mechanism, it favors the passive diffusion across concentration gradient from high concentration to low concentration. When we talk about the active transport, so there is a basically transport of the polar ionized molecule of size greater than 50 Daltons. So basically the distribution of the drug, it involves multiple steps. So what is the rate limiting step? So rate limiting step, it involves the rate of perfusion to the ECF. What is the membrane permeability of the drug? So distribution is basically a passive process for which the driving force is the concentration gradient between the blood and the extravascular tissues. So this process occurs by the diffusion of the free drug until a equilibrium is established between the peripheral and the central compartment. What are the factors affecting the distribution of the drug? So the prime factors which are responsible for the decreased distribution or increased distribution, it depends upon the molecular size, degree of ionization, pKa, and oil water partition coefficient. The physiological factors, it include the physiological barriers to diffusion of the drug, like we have the tissue permeability, what is the perfusion rate, and what is the organ tissue size, which mainly affect the distribution. Binding of the drug tissue compartment, like the blood component and like the extracellular components. Miscellaneous categories, it includes like age, pregnancy, obesity, diet, disease state, and the drug interaction. First is the physicochemical property. So the molecular size weight that is less than 500 to 600 Dalton, it easily passes the capillary membrane to the extracellular fluid. So the penetration of the drug from the ECF to cells is basically function of its molecular size, its ionization constant, and the lipophilicity of the drug. For from the extracellular fluid to cross the drug between different cell layers through aqueous filled channel, it needs a particle size less than 50 Daltons with marked hydrophilic properties. So the drug is basically which imparts the hydrophilic nature and a size less than 50 Dalton. It easily crosses the ECF membrane through aqueous filled channel. So distribution of the larger molecular size, they are restricted or it requires specialized transport protein for transporting the molecule from different compartment, that is from the blood to the peripheral compartment. Degree of ionization, the pH at which a half of the drug is unionized is called pKa. A weak acid, it become unionized in a stronger acidic environment, A weak acid, it become ionized in a basic environment. So when we talk about a weak base, it become unionized in a strong basic environment. A weak base, it become ionized in a acidic environment. So basically, we need a opposite type of pH to ionize the molecule. So the pH of the blood plasma or the ECF or the cerebrospinal fluid is around 7.4, which is held constant except in the case of acidosis or alkalosis. A drug which ionized at plasma pH, it cannot penetrate the lipoidal cell membrane. So basically, when we talk about the permeability, so there are the two steps. So when we talk about oil water partition coefficient, or when we talk about the lipid membrane partition coefficient, non-polar and hydrophobic class of the drug, they are easily cross the cell membrane because of high hydrophilicity. When we talk about non-polar drugs, they are less likely to cross the membrane due to poor permeability. So in case of polar drugs, where permeability is the rate limiting step in the drug distribution, the driving force is basically the effective partition coefficient of the drug that can be calculated by the given formula. That is, effective partition coefficient is equivalent to KO by W. That is the basically fraction unionized at a pH of 7.4, and KO by W is basically fraction of unionized drug at a particular pH, that is pH 7.4. So lipoidal drug, it penetrates the tissue rapidly. So among drugs which having the same oil water partition coefficient but different in the ionization of the blood pH, it easily cross the membrane. So once which has the less ionization, it show better distribution. For example, phenobarbital. Phenobarbital, it having that better distribution as compared to salicylic acid. So both are having the same oil and water partition coefficient, but phenobarbital itself, it becomes less ionized at blood pH. When we talk about the example that including the thiopental and salicylic acid, thiopental, it having that basically it's a weaker acid. It is around effective partition is around 2 at a pH 7.4. So it having the relative rate of distribution is around 80%. Salicylic acid, it basically is a stronger acid. It having that oil water partition coefficient, it around 0.005. It having that low rate of distribution, that is less than 1. So it show better distribution when it become less ionized. What are the physiological factors which affecting the drug distribution? There are basically three major factors. That is called physiological barrier, in that is basically impart the tissue distributability of the drug. What is the perfusion rate and what is the organ tissue size? When we talk about the physiological barrier, so some of the important and specialized barrier which impart the tissue permeability of the drug, it includes the simple capillary endothelial barrier, simple cell membrane barrier, blood-brain barrier, cerebrospinal fluid barrier, placental barrier, and blood testicular barrier. When we talk about the simple capillary endothelial barrier, so the membranes of the capillary that supply blood to the most of the tissue is practically speaking, it's not a barrier. Basically, it having that function to supply the that is called the neutral blood to the developed moieties which we called as the potent drugs. So thus all the drugs, whether it is ionized or unionized with a molecular size less than 600 daltons, it easily diffuse through the capillary endothelium and into the interstitial fluid. So only the drugs which bound to the blood components, they are basically restricted because of the larger molecule size of the complex. Now, simple capillary, that is called simple cell membrane barrier. So once a drug diffuses from the capillary wall into the extracellular fluid, its further entry into the cell is restricted by its permeability through the membrane that lining such cell. So such a simple cell membrane is similar to the lipoidal barrier in the GI absorption of the drug. So when we talk about the simple cell membrane barrier, it includes or it containing the extracellular fluid which impart the transport of the drug from the peripheral to central compartment and is restricted because of molecular size, is restricted because of tight junctions inside the cell membrane. Basically, the transport mechanism, it also depends. So that which type of the transport mechanism favorable to a particular drug, that it also restricts through the simple cell membrane barrier. Second is the blood-brain barrier. So the capillaries in the brain, they are that are highly specialized and are much less permeable to the water-soluble drugs. So the brain capillaries, it consists of endothelial cells which are joined to one another by the continuous tight junctions that comprises called blood-brain barrier. So the presence of special cells that are called astrocytes, which are the segments of the supporting tissue found at the base of endothelial membrane, it solid envelope. So the intercellular process is to gain the cells from the capillary circulation into the brain, it has to pass through the cells rather than brain. It containing the tight junction, and it held by the different cell membranes. So the glial cell is basically one of the important cells which through endothelium. The tight intercellular junctions basically able to cross the drug which having the on the molecular size depending on the polar to non-polar ratio. The passage of the drug is concentrated. The concentration is basically dependent upon the what is the tight junction behavior, what is the permeability of the different approaches to target blood. So, use of the permeation in answers such as dimethyl sulfoxide, it improves the permeation. So basically, the mechanism it involves osmotic disruption of the blood-brain barrier by infusing the internal carotid artery with mannitol. So use of the dihydropyridine redox system is also used as a drug carrier to the brain. So lipid-soluble dihydropyridine is linked as a carrier to the polar drug to form a prodrug that readily crosses the blood-brain barrier. So in the brain, the basically the enzymes to back of the this type of the redox reaction that has been used below steroidal drugs to the brain. Next is the blood cerebrospinal fluid barrier. So the cerebrospinal fluid is found mainly by the choroid plexus of the lateral third and the fourth ventricle, and it is similar in the composition to the extracellular fluid of the brain. So the capillary endothelium that lines the choroid plexus have containing the open junction or gaps and drug that can flow freely into the ECF space between the capillary wall and the choroid cells. It imparts the greater permeability. However, the choroidal cells they are joined to each other by the tight junction, it forming the blood CSF barrier, which has the permeability characteristics similar to that of the blood-brain barrier. So it improves the permeability of the different molecular weight compounds. As in the case of blood-brain barrier, only highly lipid-soluble drugs that can cross the blood CSF barrier with relative ease, whereas the moderately lipid-soluble and partially ionized drug it permeates slowly. Next is the placental barrier. So it is the barrier it between the maternal and the fetal blood vessels. Basically, it's separated by the number of the tissue layer that made up of the fetal trophoblast basement membrane and the endothelium, which together constitute the placental barrier. So the human placental barrier, it has a mean thickness of 25 microns in the early pregnancy that reduces to 2 microns when basically in the non-pregnant condition, whichever, but when we talk about the effectiveness, it doesn't reduce. This is basically the outline depiction of the placental barrier that containing the fetal vein, fetal arteries, and basically it is separated by the fetal trophoblast membrane, which supplies the blood consistent and nutrient to the fetus. It also contains the maternal artery or maternal vein, which has basically the restrict the passage of several endoplasmic molecules or lipophilic molecules to the fetus or to the placental barrier, which prevents the contraception. So, which prevents the contraindication that prevents the congenital defects in the baby. Mechanism. Many drugs having the molecular weight less than 10,000 dandelions and having that moderate to high lipid solubility, for example, ethanol, sulfonamides, barbiturates, gaseous anesthetics, steroids, narcotic analgesics, or some anticonvulsants, they cross the barrier by the simple diffusion mechanism. This shows that the placental barrier is not as effective as a barrier as compared to blood-brain barrier. So nutrients it essential for the fetal growth, they are transported by the carrier-mediated process. So immunoglobulins they are also transported by the endocytosis. So drugs they are particularly dangerous to the fetus during two stages. So in the first trimester, when the fetal organ develops, it is during this stage that most of the drug shows their teratogenic effects like the congenital defects, for example, thalidomide, phenytoin, isotretinoin, testosterone, and methotrexate. In the later stages of pregnancy, when drugs are known to affect the physiological function, for example, the respiratory depression by the morphine. It is therefore always better to restrict these drugs during pregnancy because of the uncertainty of their hazard effect during the fetal development. Brush testicular barrier. So this barrier is located at the capillary endothelium level, but at the Sertoli cell junction. It is a tight junction between the neighboring Sertoli cells that act as a blood testicular barrier. So this barrier it restricts the passage of the drugs to the spermatocytes, and it also prevents the spermatogenesis and oogenesis during the reproductive development. Perfusion rate. So distribution is basically permeability rate limited in the following cases. When the drug is under consideration and is basically ionic, polar or water soluble. When the highly selective physiological barrier, it restricts the diffusion of the such drugs to the inside of the cells. So distribution, it will be perfusion rate limited when the drug is highly lipophilic in nature. So the membrane it across which the drug is supposed to diffuse is highly permeable, such as those of the capillaries and the muscles. So in both circumstances, the rate limiting step is the rate of blood flow or the perfusion to the tissues. So greater is the blood flow, faster is the distribution. The perfusion rate it defines as the volume of the blood that flows per unit time or the volume of the tissue that flows per unit area. So it is expressed in the ml per minute of the tissue. So according to the total body volume that we assume in that is assumed as a 70-liter fluid, the perfused organ that compared as highly perfused like the lungs, kidneys, adrenal glands, liver, heart, or brain. The moderately perfused organ like the muscles, skin, and the poorly perfused organ like fat, that is the adipose tissue, and the skeletal muscles. Organ tissue size. So the extent to which a drug is distributed in a particular tissue or an organ, it depends upon the size of the tissue. That is the basically tissue volume and the tissue blood partition coefficient of the drug. Example, that is the case of the thiopental case study. Thiopental is a lipophilic drug and has a high tissue blood partition coefficient towards the brain, and it's still higher for adipose tissue. So since the brain is a highly perfused organ, following the IV injection, thiopental readily diffuses into the brain and it's showing a rapid onset of action. So adipose tissue, it being poorly perfused, take longer to get distributed with the same drug. So, but as the concentration of thiopental in the adipose proceed toward the equilibrium, the drug it rapidly diffuses out of the brain and it localizes in the adipose tissue whose volume is more than 5 times than of the brain and has a greater affinity for that particular drug. The result is the rapid termination of the action of thiopental due to the highly tissue redistribution and it encompasses with high BD. So binding of the drug to tissue compartment is one of the factors which affect the distribution of the drug. A drug in the body it can bind to several components such as the plasma proteins, blood cells, and the hemoglobin that is basically blood components, and the extravascular proteins and the other tissues. So miscellaneous factor affecting the drug distribution like the age of the patient. The differences in the distribution pattern of a drug in different age groups, they are basically differences like in the total body wear, total body water, it including the both intracellular and extracellular fluid, is much greater in the infants as compared to elderly. Fat content is basically equalized in the infants and the elderly, so there is no much effect on the distribution. Skeletal muscles, they are lesser developed in the infants, but they are more in the elderly. Organ composition, the blood-brain barrier is poorly developed in the infants, so the myelin content is the low, so hence there is a greater penetration of the drugs in the brain in the infants as compared to elderly. Plasma protein count, there is low albumin content in the both infants and the elderly, it causes the poor distribution in the both of the ages. Pregnancy. So during pregnancy, the growth of the uterus, placenta, and the fetus it increases with the increase in the volume available for the distribution of the drug. The fetus it represents a separate compartment in which a drug can distribute. So the plasma and the ECF volume it also increase, but there is a fall in the albumin content. So when we talk about the fall in albumin content, the ECF sudden rise. So that is causes that is basically creates a harmful effect in the growth of uterus, placenta, and basically outcome is that is a defection in the pregnancy rate. So we need that is called we need a increase in the albumin content. We need the proper growth of uterus and the fetus during the pregnancy, so that the distribution of the drug will not play a defection role in the what we call as the destruction of the fetus in the pregnant woman. Obesity and the diet. So in the obese patient, the high adipose tissue content that can take up a larger fraction of the lipophilic drug, despite the fact that perfusion through it is low. So the high fatty acid level in the obese person, it alters the binding characteristic of acidic drugs. A diet high in the fat will increase the free fatty acid level in the circulation, so thereby it affecting the binding of the acidic drugs such as the NSAIDs to albumin. Disease state. So alteration of the drug distribution characteristics in disease state like the altered albumin and the other drug binding protein concentration, it improves the drug distribution in the disease state. Altered or reduced perfusion to the organ or tissue, it will also improve the distribution in the disease state. So the altered tissue pH, when we talk about distribution in different tissue, it decreases the distribution in the disease state. For example, altered permeability due to the physiological barriers like the blood-brain barrier. So when we talk about the inflammation condition in meningitis and the encephalitis, the blood-brain barrier it become more permeable, and thus the polar antibiotics such as penicillin G and ampicillin, which do not normally cross it, it gain access to the brain. So in a patient suffering from the CCF, or what we call in the inflammation condition in the meningitis, the perfusion rate to the entire body organ decreases, will affecting the distribution of the all drugs. So when you talk about the drug interaction, so combination formulation or the drug-drug interaction that can majorly affect the distribution, mainly due to the differences in the plasma protein binding or tissue binding of the drug. So when we talk about the competitive binding, one enzyme can displace the other drug because of the same structure similarity or the same catalytic binding, which can mainly distribute the second drug or second molecule by displacement reaction. So the questions come in the topic that is basically what are the specialized barrier which affect the distribution of the drug. Describe the anatomy and the physiology of the blood-brain barrier. What characteristics of a drug that are necessary to penetrate such barrier? What type of the nutrients which are generally been polar and make their way into the brain? Polar drugs such as penicillin that normally do not cross blood-brain barrier but do somehow in the meningitis. Explain. So name the three approaches by which a polar drug can be targeted to the brain. So these are the references which I have taken the data. So thank you very much for your kind attention. So any suggestion, details, you can contact me as a listed address. Thank you very much.